So I'll start off by just giving you a little bit of an overview of myself before I actually start, because I don't know anybody here. And I always think it lands better if you know a little bit about the person. So I've sort of put together two sort of slides that look a little bit like uh, a scrapbook, just to sort of give you a bit of an overview of who I am. So can I have the next slide, please? And so before I actually get started in my presentation, I thought I'd sort of just tell you a little bit about myself and my background. Born and bred in Birmingham, grew up here. I'm the daughter of one of five girls to my parents who were from the Caribbean. Um, Went away and studied and came back home. I got my first job at Birmingham University. Had no clue what I was going to do because I did physics, chemistry, biology A level. I wanted to do medicine at one stage, but my chemistry was never strong enough. And I knew I wanted to do something um, that linked into medicine in some way, that linked into healthcare, but I wasn't really sure what that was going to do. So even after I'd got my degree, I didn't really know what I was going to do next. And I got my first job at Birmingham Uni as a research scientist in the labs. I started off in the Department of Immunology and moved on into life and health sciences in different parts. I did a lot of cell biology type work along the way. Um, I also worked at Aston Uni, and while I was at Aston University, so I worked at Birmingham for quite a while, over 14 years, did a little stint at Aston, and the work I did there was around the European research projects. So did a lot of work with different academic partners from overseas, did a lot of European stuff, um, lots of traveling. It was great. Spent a lot of time in Brussels, with governance and rules and regulations around research. So that was my initial background. Can I have the next slide, please? And then I moved on to do my PhD, which was in the liver unit. So you can see here on the left a dialysis machine, and my PhD was developing a bioartificial liver machine. So that's my work on the right-hand side, trying to develop a liver, a machine that could actually keep somebody alive. So the concept was just in the same way that a dialysis machine works. That could we isolate hepatocytes from a liver? Could we get them into a reservoir and culture them and get them to mimic a real liver? And so my job was to mimic that real liver. If you look at section D, you'll see there's a little reservoir there. That's where the cells are. And those fluids in sections A and B, those are representing the blood, and there's oxygen and all sorts of things flowing through there. And I did a lot of liver function tests. And the answer was yes, we could get it to mimic the liver. Unfortunately, when I finished my PhD, there was no more funding for us to continue with that work. So I moved on to do other things, and that's when I moved on to Aston. So that's really my background in a sort of potted summary. And after working at Aston, I started a job back at Birmingham Uni working with primary care. So partly at the university, partly in primary care. And that's when I got introduced into working in the NHS. And then I moved across as a research manager. And then a few years ago, just before COVID, I became the director for research and innovation. So that's just a little potted summary of my background. So can I have the next slide, please? So now that I am the director, I thought, just so that you could see who I work with. This is the majority of the team. The two gentlemen on the left, they're actually not employed. They're actually volunteers. They're public volunteers. One's a retired GP, and the gentleman on the end in the red sweater, he lost his wife to motor neurone disease many years ago and has sort of dedicated himself to supporting research. And he's a fabulous advocate for research in our organisation. The gentleman second in on the right, that's my old boss from Birmingham Uni, who's now retired, and I've roped him in to try and be our funding advisor within the organisation. So I think one of the key things in making things work in the community is you just don't have any resource. So you have to use whatever you can, wherever you can, and just pull in on friends and colleagues to actually help out where we can. Next slide, please. So I also thought it would be useful to give a very brief overview of my organisation. So I'm introducing Birmingham Community Healthcare Trust, which we refer to as BCHC. So BCHC has 5 divisions. We have an adult specialist rehab unit. We have adult community, children's and families, learning disabilities, and dental. So we have a dental hospital. We only cover learning disabilities for adults. Children's and families is predominantly school nursing, special schools, lots of services that support children with special needs. The adult community stuff, I think, speaks for itself. It's a multidisciplinary team. And the adult specialist rehab, those are our bedded areas. So we have over 5,000 staff. We have 2 hospitals, which Kirsty was mentioning before, Moseley Hall Hospital and West Heath Hospital, and we have 3 residential care sites as well. We have over 260 beds. However, during COVID, it was way over 300 beds, and we serve 1.1 million citizens. Next slide, please. So here's my first question. My first question is, could I ask you to shout out the names of NHS organisations that are renowned for research? And once you've shouted it out, could I ask you to put it in the chat so that we can actually log it and record it? So who wants to go first? Just call out hospitals that you know are really famous for doing research in the UK.
Great Ormond Street.
Great Ormond Street. Could you please get that in the chat, please? Somebody else.
Papworth.
Yes, please. Put that in the chat.
Oxford University.
Oxford.
King's College.
King's College. Thank you.
MPFT.
Sorry, there were 2 there. What was the first one?
MPFT Stafford.
MPFT.
Nottingham University Hospitals.
Yes.
Birmingham.
Birmingham, yes.
University Hospital Birmingham, UHB.
Yes. Did somebody say Great Ormond Street and
Cambridge?
Brooks.
Adam Brooks is a very big, famous.
I've done research there.
Yes.
Yeah.
So.
Sorry, I've got another one.
Yes.
University Hospitals of Leicester, predominantly Glenfield Hospital for its cardiac and respiratory research.
Yes, thank you. So thank you for that exercise, because it's actually proved the point. The point is, all of the hospitals that you know of that are famous for doing research, and I know that Gulshan said MPFT, but that's a bit of an outlier, but the majority of them are acute hospitals. How many community hospitals or community trusts are famous or renowned for their research? And if they're not, why not? So that's what we're going to look at today. Now, I'll leave the floor open for a few seconds if anybody wants to ask or challenge or say anything. I've got the screen in front of me, so I can't see hands.
Lynn's got a hand up.
Lynn? Yes.
Yes, I've got my hand up. I think because community hospital trusts don't tend to be the large trusts that are attached to the big universities, and so there isn't the associated funding for it. And a lot of the community hospital trusts focus on older people, and you know, there is age discrimination in that they're not seen as a group of people that need to have research invested in them, whereas children's research is seen to be important. So I think there's quite a number of factors in why I don't think that we are, you know, have high profile in community trust in the research landscape.
Thank you so much for that. So we're going to sort of explore that a bit more as we go through the presentation later on. Can I have the next slide, please? And thank you all for taking part, because it wouldn't work very well if everybody stayed silent. So I was talking about my organisation, and I wanted to give a few examples of some of the research that is happening within our organisation, because as we've just said, community trusts, our research is usually not high profile, but we're doing a variety of really good things that we probably need to shout about a little bit more. So I've picked 5 different examples of some research that's going on in our organization, just to give you a flavor of some of the different types of things that are happening in our organization. So 3D printing of dentures, that doesn't really need much of an explanation. It's a really good project that we found that you can get a better fit of the dentures. It's smooth, it's efficient, it's quick. And so that's a really good piece of research that's happened. The language game is for patients who've had aphasia and after stroke and they can't speak. Usually you will have a speech and language therapist assigned for a certain amount of time to support somebody. And one of our speech and language therapists has designed a game, and it's called the language game. And she's conducting that piece of research at the moment where she's working in groups. And what we're finding is that people are actually, there's 2 things she's doing. She's actually having intense sessions. So perhaps a few sessions in the, a longer session in the morning, a break, and then a session in the afternoon with a group of about 6 people with a board game. And what we're seeing is fabulous results of improvement in speech. So that's another piece of research that's currently ongoing. We do have some digital projects, so I just picked one of them at the moment, and there's a project called Isla Care. Now, this one actually started out of some EDI work, because what we found is that wounds in darker skin are so much more difficult to be identified early. And so they are usually only identified at a later stage. And so we're doing some work with this company called Isla, and they have a digital platform, and we want to encourage self-care and self-management. So it involves taking images on a smartphone to be able to identify the wound and assess the grade of the wound. This is actually going to be a really important piece of work, because in the future, we would like to go down a route of getting AI to work to support this type of work, to help us to be able to identify wounds. At the moment, there aren't enough images, especially of darker skin, for us to be able to do any AI work in this field. So this is the beginnings of a big piece of work that should take traction and have, look out for that piece of work in the future. There's a project called the I Know study, and this is around challenging behaviour in children, and tools and educational information to support parents. And the final study is ELSA, which is a type 1 diabetes children, where we're doing some screening of children who, between the age of 3 and 13 by a finger prick test. So these are just a few snippets of different varieties of research that is going on within our organisation. And I'm pretty sure that most other community trusts are doing similar things, but they, we're going to look in a bit more detail about those challenges around doing research in the community. Next slide, please. So now I'm going to just talk about the CHA study where we took part. And I don't really want to spend too much time on this because this is published information. I just really wanted to highlight some benefits of doing this type of work. Next slide, please. So we provided, during the pandemic, we engaged with the association and provided a few examples and some use cases and case studies of some of the work and some of the improvements that have happened within our organisation. And I must admit that I didn't believe our trust could move that quickly to do anything, because prior to the pandemic, things did tend to take quite a long time, but I saw things change really quickly. I saw services build and services change and adapt really quickly during the pandemic. So it just goes to show that it can be done. So before I go into this, I just really wanted to highlight the fact that it's well documented that research active organizations have better healthcare outcomes for their patients. And the amazing part of that is that they even have improvements within the services where there is no research going on. And that's to do with attitude, it's to do with approach, it's to do with the culture of the organization. And it's something that I'm really keen on working on and focusing on within our organization, is trying to change that culture and try and build a more can-do, inquiring, evidence-based approach to healthcare, because it will eventually bring us to better results. So here's an example of that. So the problem was that we have PEG site versus NG tubes. So prior to the pandemic, the PEG procedure happened in the acute trust. But during the pandemic, the procedure was paused because they just didn't have the space to actually manage these patients. So they were providing them with nasogastric tubes instead. However, the community trust didn't take the NG tubes for many reasons. But for example, you used to have the elderly people who may be a little bit confused, maybe trying to pull the tubes out. So it was something that didn't happen within our organization. And so the solution to that during the pandemic was that some of the community nutrition team were redeployed. And so they redeployed them to the community hospital to train the registered nurses to be able to manage the NG tubes. And so the healthcare assistants and the allied healthcare professionals were also trained by the specialist dietitian to be able to manage this work. And so moving forward, the benefits of just this tiny little example is that one benefit is that we now are able to, there would be a number of patients who would have been denied high quality care during COVID if we hadn't managed to make some sort of change. So that's one thing. Another thing is that the patients with these tubes will continue to be administered for early rehabilitation through our organization. So that has actually changed practice on the wards so that they feel more comfortable and confident to be able to manage patients of this nature. The profile of the patients being seen in the community hospital has changed. And finally, this challenged staff to develop additional skills and gain confidence in managing different situations. So this brings us back to that comment that I made at the beginning, that research active organizations and doing things with inquiry-based, with an inquiry base or quality improvement actually does start to chip away and change approach, and it improves the skills of all the staff, not just the staff who are involved in that work. So that's just a small example that I wanted to give you. Can I have the next slide, please? So during the pandemic, we were also heavily involved in a number of pieces of research. So at the very beginning of the pandemic, we redeployed the team and the nurses went back to the frontline doing work. Those who were not clinical were doing supporting roles. I ended up in the kitchens at Moseley because I have a food and hygiene certificate. So I ended up frying fish and serving food in the hospital canteen because they were short-staffed. So, you know, everybody mucked in and did whatever was needed at the time. But the first pieces of research around COVID clearly were around the acute sector. But then after a few months, then more research was coming out that was going to be suitable for community trusts to get involved in. And I haven't put all of the examples here, but I have put a few examples of some of the research that we were involved in during that time. So COVDent is a COVID dental study to determine the seroprevalence of antibodies from the dental care professionals. And that piece of work, we fast-tracked it so that it could open, and it has been a phenomenal piece of work to be able to give answers to healthcare professionals to be able to understand how to keep dentists safe after COVID. ISERIC is a national study, and this was again looking at screening. It's a very dry, boring piece of work for those who want a really interesting piece of research. Some people may say it's not boring, but for me, sitting and looking through data, looking through patient records, day in, day out, recording things, uploading that data onto a database, it can be quite dry. But actually, the exciting part is once all the data is collected from all of the different sites and you start getting answers. For example, ISRIC was part of the one of the studies that identified that lack of sense of smell was something that came out during COVID, and it's really nice to be part of a bigger piece of work like that. We also took part in a study called Siren, which again was screening of healthcare professionals so that we could understand a little bit more about the immunity, the antibodies, whether we needed regular vaccination or not. And Siren was one of those national studies that helped us to identify the fact that the antibodies waned after a period of time and a booster was required. Then I've put down 2 SCIDS studies here. So SCIDS was a surveillance study in children. It was looking at the bubbles that the schools put the children in. Did those work? And so we initially went into school and we were screening children and teachers, saliva samples, nose swabs, and sending those off. And then SCIDS Plus, they asked us to go back in and do a longitudinal study. So the first piece of work was a lot of schools going in and doing those swabs. The second part of the work in the second year was identifying a few schools, but then assessing them over the 12-month period each quarter, and going back into the schools, but this time taking blood samples as well. So you can imagine what going into a school and taking blood samples was like, because you're in a non-clinical environment trying to do a clinical task. But we managed quite well with this piece of work. And so in summary, from this section, I think the learning is that we want to encourage people to be able to think and inquire about how to continuously improve what we do. If there is anything good that can come out of a pandemic, I think what it's done in our organisation is raised the profile of research and innovation. Before, research and innovation was considered as a bit of an add-on. And I think during the pandemic, we received greater profile because of the research that we were doing and taking part in. So if anything good can come out of a pandemic, I would say that that's one thing that has helped in our organisation. And it's also helped to have an executive team that's extremely supportive of the work that we do and recognising the value that we can add to the healthcare of the organisation. So can I have the next slide, please? So that brings us to the end of that first section. So I just wondered if anybody had any questions or any comments about the summary of some of the things that we had done over the last few years, and our sort of growth in research activity over those few years.
I suppose my thoughts that I've written down is that a lot of the research that you've done is very relevant to the community, the trust that I was working in, very relevant, and I'm sure will be again very relevant to the other community trust across the UK. And so I suppose maybe you are going to come to it. I suppose, how do you disseminate that research and learn from each other between the trusts?
Yes, so that's where I'm coming to now, so thank you. So that brings us nicely to exploring R&I and community hospitals. So I should add as a caveat, we've said community hospitals, but a lot of the work we do is either in our community hospitals or in out-of-hospital settings. And I think that's one of the challenges that we do have, is that the designs of most of the research is around acute or perhaps around GPs. And and we're just a different kettle of fish, and it just makes things really difficult. So I'll take you through some of this, and then I think that may open up a discussion that we can talk about what the challenges are and how we can improve things for the future. So can I have the next slide, please? So as we talk about community trust, this is where I'd like to introduce CHART. So one day, I've been in this organisation for over 10 years now, and I think it was about 6 years ago. I was just trying to get some research going, supporting some researchers, and everything's just really, really difficult. And so one day I'd just had enough, and I sat there and I went online and I looked around for some other community trusts. And
Oh, have we lost Chris? Is she did she,
Sounded like she dropped out, didn't she?
yeah, sounded like she just dropped out. Will she be able to rejoin, Helen?
Sharing. All right. I'm hoping she'll just come back in.
Can the link just allow you to come back in? Is that, yes, it can. Okay, that's good. That's good.
There she is. She's
Oh
there.
yeah.
Yep.
Yeah.
hello, am I back? I just got a
Hi.
message flashing up saying I had a weak signal, and then I disappeared. So I'm really, really sorry about that. Can you all hear me?
Yes.
Oh, great. So I'll start that section again. So if we can get back to there we go. Thank you. So one day I was just thinking it's just so difficult to get research done. Surely I can't be the only one struggling. So I thought,
Oh dear, we lost her again.
Yeah.
yes, and I'm back for the
Oh, you're
second time.
This is
I don't
exciting.
understand. And I've got a booster in my house. I just don't understand what's happening. I'm really sorry, everyone. If I'd have known this was going to happen, I'd have stayed at work. So I thought this is just too difficult. Let me just email around and see if anybody else has the same challenges. So I managed to find a few other community trusts. I sent an email and said, you don't know me. I'm, a research manager in my organization. I said, here are some of the challenges and barriers I have. Do you have the same? And if you do, would it be worth us meeting to discuss this? And I invited them to Birmingham if they wanted to. And I had an immediate response of at least 7 people saying, that's exactly the problem. And yes, let's meet. So that was when the first time that a number of community trusts met together back in end of 2017, early 2018, we met and had some discussions. And that was the birth of really thinking about coming together to create an alliance. And that was the birth of CHART. So CHART stands for the Community Healthcare Alliance for Research Trusts. But since then, it's actually morphed and changed and grown into out of hospital settings rather than just community. Because the more we move in this direction, we're recognizing the engagement and the interconnectivity that is required between our organizations, public health, social care, GPs and primary care. It's all interconnected in out of hospital settings. So that's really the strength that in the area that and the direction of travel that CHART is going in, to try and support each other with best practice, sharing and learning from each other, sharing documents, sharing, any resources that we have, sharing JDs, anything like that. That's what we've started to do in CHART. So can I have the next slide, please? And I'm hoping I don't crash and drop out again. So was it Lynn who started talking about some of the challenges we have? Was it? I can't remember her name, sorry. The lady who was giving some examples of why she thinks that community trusts aren't as renowned for research as
yes, It was Lynn, yeah.
It was Lynn. Okay, thank you. So I've tried to categorize these and I've really simplified them for these slides. But I'll just try and go through this. Some of our research challenges are capability and capacity. The staff just do not have the capability and they just don't have the capacity. And if you don't have line managers who recognize the value of doing research, it becomes really problematic to have people who want to do something and just can't get a break and can't get that support to get that done. And within an acute setting where there's a lot of research going on, it's easier for people to recognize that people may want to do some research. But in a community trust, especially if there is no very low research activity, it can be quite difficult and challenging. And there's also a lot of training needed. People need a lot of hand holding to be supported, to be able to do the research that they want to do. And there's limited funding. Again, this is what Lynn mentioned. And we put together, on that day when we met, we put together a SWOT analysis. That was what we spent the afternoon doing, saying, let's analyze what the issues are. I do have a SWOT analysis on the next slide after this to go through. So problematic processes. There's limited guidance for doing research in out of hospital settings. So when you're looking for guidance and you've done your IRAS forms, so for those who don't understand that language, these are the application forms and the for doing the processes for doing research. A lot of the processes are designed around the acute sector, so where you're recruiting from one site, where everybody comes into one base, there's one footprint for everything. But how do you do research when you may be doing it in people's homes, or you may be doing it in clinics, or you may be doing it in the community, or in, when they come for their outpatient appointment. And there isn't that much guidance for doing it that way. Very often for certain clinical trials, especially, and for other studies, you need medical oversight to do research. But in a community hospital and in community trusts, there are very few medics. So you will have physio practitioners, you will have consultant physios, you may have, a number of other advanced nurse practitioners who run services without medics. And so when we're offered opportunities to be involved in research, it becomes problematic because we then have to find a medic or even pay a medic to have oversight of the study so that we can do it. So we end up paying for the privilege of being involved in research because the model doesn't work for us. And so those costs and the funding doesn't work for us either. So for example, if you're not familiar with research and how the funding works, very often the funding follows the recruitment, the accruals. And the example I usually use is stroke services. So if the acute sector, the acute hospital is recruiting 20 participants who've had a stroke, they get the accruals. But if the research requires that participant to be reviewed or screened or assessed for 12 months, we do all of that 12 months of assessment, but the accrual's gone to the acute hospital. So now community trusts are getting a bit more wise to this. And so the solution to this is about negotiation. It's about having the conversation early and saying, okay, we want to do this study. Actually, let's try and do this together. How do we share the load? How do we share the funds that come in? And so we're trying to now develop these relationships with our local NHS partners so that we can do things in a better way. There are only a few suitable studies. One of the challenges around research design is that most people who understand the NHS as researchers, whether you're academics in the university, they understand the NHS as the acute section, but they don't quite understand community. And that's because community is so complex. There are no two community trusts that are identical in the services, in the processes, in how they're funded. And so these make it quite challenging to actually do research. So the solution to that is to be a bit more bespoke you want to speak with your researchers at the very beginning of the study. We've had studies where people have approached us after they've designed the study and they've costed it. And then they come to us and say, oh, it's all right, we've gone through all the processes, we've costed the study, but the study still doesn't work for us because the costing won't work for us because of the model of the way we work. And so we're learning more as we go along as how to make these changes. I've already talked about limited suitable studies. And we also need to learn how to link to public health, to social care, etc. And early engagement is key. Engaging with anybody that you want to do research with, it's key to have those conversations early, even before the applications for funding have been submitted. Can I have the next slide, please? So the next slide is really a sort of a SWOT analysis of those challenges. And I won't go through this slide, but I've put it there so that if anybody is interested, they can look at the strengths, the weaknesses, opportunities, and threats of doing research in community. And sometimes the strength is the weakness. So, for example, a large footprint. If you live in a rural area with a large footprint, it's extremely difficult to then get around and do research. But actually, it could also be an opportunity to have a large footprint, and perhaps it may bring some diversity to your research. So there are some of those here where I've said that one is a strength, but it could also be a weakness. I'm not going to go through this slide. I've literally just left it there as a reference point. We actually put this slide together in 2018. And I've just looked through it, and apart from removing STPs because they no longer exist, all the rest of it still exists as it stands. So I've left the slide more or less the same. So can I have the next slide, please? Because I'm going to go through that in detail. So just highlighting some of the other complexities of conducting research in the community. There are a list of community trusts, and they are listed in this table through the NIHR, and our local clinical research network have almost like league tables of performance. So we are all held accountable by the performance of our research and our research recruitment, the accruals that we get. And so it's almost like a national table of league table. And you would expect the acute trusts to be higher, but I do think there are things that we can do to actually contribute towards research and improve the healthcare of the patients that we serve and the communities around us. So I've just put that in as a fact around the fact that there are 14 trusts with the word community and 6 organisations that are care trusts. So there are about 20 community trusts in England. Many of them have this sprawling, large geography. Most of the community trusts are integrated with their local authority, with social care, the third sector. The top 5 areas for research in the last few years are highlighted here. So these are the areas that research in community trusts has been identified as being the top areas. A lot of mental health research and musculoskeletal work, dementia, primary care, and then health service research is quite generic, and that probably covers all sorts of things. And also, we're at a stage where we probably need some new research models, because randomized controlled trials used to be the gold standard. But within a community trust, that model doesn't necessarily lend itself to, I've said, the messiness of normal people in their own communities. And so sometimes we need new methods or different methods or creative ways of being able to engage with groups or communities to be able to get their feedback. And I think those organizations that actually manage the ethics around research are now just catching up with the fact that we need things to be creative and different to be able to support the type of research that we need to do in the community. Can I have the next slide, please? So with CHART, we started off by looking at the barriers, and those are the ones that I've just gone through so far, and we did the SWOT analysis. But then after that, because we'd recognized that we were at a disadvantage before we even got started, because the funding didn't work for us, the way that the accruals worked didn't work for us, we thought that the best approach would be to go to the National Institute for Health Research administrators. And so Dr. Louise Wood, who works for Professor Chris Whitty, at the time, she was the Director for Science Research and Evidence, and we approached her and we managed to have some conversations with her. She invited us back again to have further conversations to try and understand a little bit more about the challenges being faced by us. And they actually opened the door for CHART and supported us to be able to make a case for change. And we've felt really supported. So we've engaged with CHART, and in the final column, you can see that we did launch, but obviously during the pandemic years, we've just been meeting with people bi-monthly online, just to share and learn amongst each other. There was a time where some people wanted to do vaccine trials, so we would I think we invited MPFT, Midland Partners Foundation Trust, to come along and give a presentation of what they had done to actually set up a vaccine hub in the community, so that others can share and learn and share documents and learn from each other for processes, etc. So that's how we actually got started with CHART. Can I have the next slide, please? So this is the working group, and pretty much most of these people in this picture were there from the very beginning. They were some of the people that responded and said, yes, these are the challenges. So we became the working group, and beautifully representing all the different areas of the country. So Derbyshire as the East Midlands, me, the West Midlands, then you've got Solent, you've got London, Hounslow and Richmond, you've got Kent and Sussex. We did have somebody from Leeds, but they've now retired. So we need somebody from up north to represent. So can I have the next slide, please? And this working group is fabulous. And we actually live by this statement here for CHART. If you want to go fast, go alone. But if you want to go far, go together. And so we have worked together over the past few years to try and think about what the key issues are and see if we can chip away at them and actually have a collective voice to actually take that collective voice to the NIHR. And that's what we've been doing, is sort of talking to the NIHR about some of those issues, and they have been listening. Can I have the next slide, please? So this is a picture of us looking all bright and young and bushy, really interested and keen. This is us sitting at the Department of Health and Social Care in London. We'd all travelled down to spend time to go and meet Dr. Louise Wood. And so you can see here, there were 3 times that we went down to have these conversations. And we were invited, we thought it would be a one-off, and she invited us back to talk to the Director of Finance for the National Institute for Health Research and to talk to the Director of Research for the Clinical Research Network. And we felt supported to try and make those changes that were required to actually help out. And I must say that this year, for those of you who aren't familiar with the research world, there is some funding called research capability funding. And most community trusts are exempt from it because we just don't hit the targets. And once we'd had these conversations, this year, there's been a change, and a significant number of community trusts are now able to get that first step of research capability funding. It's only £25,000, but for a community trust to have £25,000, that could be a part-time nurse to help with a project, or it could be a part-time physio or whatever, to try and help build some research capacity within an organization. And it's just little steps that will actually help to try and generate some more funding in the future. Can I have the next slide, please? And so this is just an activity summary of what we've managed to achieve so far with CHART, how many partners we have, the amount of trusts that are engaged. So the trusts that come to us, they aren't all community trusts. Some will be acute trusts that say, we have some community elements, could we join? And the door's open to anyone, just so that we can discuss the agenda of community. So the stats are there in the left-hand column. We've actually now started to apply for grants, because I do think that the next stage now is for us as community trusts to pull together and actually start applying for grants and have other community trusts as sites for research. So there's a lot of potential here. Community trusts are predominantly an untapped resource for doing a different type of research. So I think Lynn was talking about those, you know, the high profile stuff, cancer trials, children's trials, surgery, that type of thing. There are things that only community trusts can do. And I think we need to grow that and grow into doing more research in some of these areas. For example, we need to do more research that keeps patients in their homes longer, more digital tech, more devices that supports the patient, but also devices and digital tech that supports the carer. So, for example, I know that there are things like brain in hand, or so brain in hand is a device where the carer can actually plug in and put in information into a smartphone for a loved one who has mild dementia. So it may remind them, oh, tomorrow morning you've got to go to the doctors, or you're going to get your hair done, and it will remind them when to get up. You know, your clothes are out. It will show pictures of their children to remind them. It's got their address on there in case they get lost. And so there's a lot of things like that. So I think there's more we could do as community trusts to do research with devices, with digital tech, and new innovations and medications that we need to grow into, and that collaboration with the wider integrated system that we're now working in. Can I have the next slide, please? So just to summarize, these are the next steps that we've sort of sussed out that we need to do. And this is from listening to and engaging with the CRN, the NIHR, and listening to the leads of the new integrated care system, and the ICB representatives. So we need to grow research in community, especially after COVID. Community is where it's going to be. I don't think we're going to get back to everybody going into hospitals for things. Where possible, I think there's going to be more screening, more assessments done either in the home or in the community in some way. And I do think that the community trusts need to get ready and prepare ourselves for being able to take on the support of doing more of that work. We need to grow the research that we do. We need to collaborate more with our partners. We need to build that CHART Alliance and create a really good, robust platform for being able to do more research. And CHART welcomes all organisations to take part. Can I have the last slide? I think it is. Our ambitions. Again, it just follows on from the previous slide, to have that collaboration, to have community-based research infrastructure, to work with patients and service users. I do think as community, we need to listen to the community more. So we need to engage with community and let them have a voice as we, we work and make plans for the future. And we need to work on those new and hopefully accepted research methods and demonstrate increased diversity in research participation. And I think the final slide may just be, so we're hoping to develop a website with just information for CHART. So it's in a draft form at the moment, but that should be coming soon. And then finally, if anybody is interested in signing up to CHART, can I have the last slide, please? If anybody is interested in signing up to CHART, here are the details of the working group. And then on the final slide, Jane Clark is the administrator. And if you wanted to sign up to just be on the mailing list and engage with the CHART community, then you're more than welcome to. So